I want to go ahead and welcome everyone. I'm really excited. I'm here with Tiffany Kuebler, co founder, chief operating officer at Diagnosa, the medical director of clinical informatics at the University of Maryland Medical Center. Tiffany has a unique perspective that spans both sides of healthcare technology. She's been practicing physician assistant at the R. Adams Cowley Shock Trauma Center since 2007, where she was actually the first PA hired there and simultaneously leads teams of 20 Epic certified providers, builders, designers of EMR solutions that reduce physician burnout and improve patient care. Her company, Diagnosa, was born from a simple but critical mission: bridging the disconnect between bedside clinicians and EMR systems they're forced to use every day. Tiffany, welcome to the Digital Dose.
Thank you so much for the warm introduction. I'm so happy to be with you today.
Absolutely. Well, we are happy to have you, Tiffany. You've been working at an intersection of trauma care and clinical informatics for years. What was the moment when you realized I need to start Diagnosa to solve problems at scale? What was happening that made you say this has to change?
It's a great question. I think that something that a lot of my fellow clinicians can appreciate is that we are always looking for opportunities to help. And no matter how many people you help, you're always going to look to see, is there more that I could be doing? And I've taken that perspective into the IT world with me as well. I think that there's a lot of healthcare systems that are under resourced to solve not only sticky workflow challenges, but implement optimizations that providers are clamoring for, but they themselves don't necessarily know how to go about doing it. I was on a call a few years ago presenting a build that I had implemented at University of Maryland Medical System, and one of the folks on the call at another health system, I forget where, outside of Maryland, said, "I would love to have something like that in our system, but I don't even know where to start because IT won't even answer the phone when I call." And I've realized that the work that we have been able to do at University of Maryland is not available everywhere, and it really should be. There's such an opportunity to harness the power of the technology that we already have access
Mhm.
to make it so that when we provide care for our patients, we're not doing it in spite of the technology that we have to use. It is so that the technology can benefit us and help us take better care of our patients. And so if I can take the work that I do, my partners can take the work that they do, and we can help other organizations where they don't have someone like us and resources like us, and that helps them take better care of patients and helps them be better, less burnt out providers and clinicians. That is really what makes us want to get out of bed every day.
That's phenomenal. So on your website, you lead with a powerful statement. Clinicians are burning out on efficient electronic medical record systems. For listeners who aren't living that every day, paint the picture for us. What does EMR related burnout actually look like for a physician or a PA on the floor?
The simple thing that we tend to count is how many clicks does it take for me to do the thing that I'm obligated to do, and then multiply that over all of the things that I am obligated to do. Um, Healthcare has gotten so much more complicated than when we were on paper and when EMR systems started 20 years ago. Documentation requirements, the billing requirements, the compliance requirements, the quality and safety metrics, the the unending desire for data to help guide what we do and report on what we do. All of that ends up into the EMR, and it is translated to the clinicians that have to use it, making sure your documentation contains so many elements, making sure you see all of the medication alerts, making sure you see clinical decision support. And all of these things are important and help us provide better, safer care. But it can be death by 10,000 clicks in a day if you don't take into account the workflows, what adding all of those requirements one on top of each other mean for the clinicians that have to then use the software, work through all of those workflows and pathways when really they are using technology because they have to, most of them not because they want to. And what they really want is to be face to face with their patient and not spending the day electronically caring.
Absolutely. That is definitely near and dear to my heart, and I'll tell you a little bit later why that is. But you talk about the disconnect between bedside clinicians, administrators, IT teams, and the realities of practice in medicine. Where does that disconnect come from? Is it lack of communication, competing priorities, or something more fundamental about where these systems are built? What do you
I think it's a lot of well intentioned folks coming from their own silo with not a lot of true understanding of what the other folks are experiencing. And one of the benefits of being a hybrid, of being a clinician and an informaticist, a clinician and a builder, is that you see both worlds. You have enough knowledge of both worlds to understand a problem from both sides of the coin. Administrators have financial responsibilities, quality and safety responsibilities, compliance responsibilities. And so they are coming at it from the needs that they have. They may or may not be clinicians. They may or may not, if they are clinicians, they may or may not be practicing anymore. And so there's an disconnect, not intentional, not malicious, but sometimes a disconnect. And if you have only clinicians and analysts and you don't have someone that speaks both languages, the clinicians are on one side saying, I don't want to do it that way. That doesn't make sense for what I'm doing. This is really hard. This doesn't help. This doesn't work the way that I think or how it helps my practice. And the analysts say, but this is technically how the software works and this is what we can offer you. And what a clinician informaticist can do bridging that gap is to say, I understand the administrative needs, I understand the clinical workflow, and I understand how the technology works and what options are available and helps architect a solution that meets administrative needs, is efficient from a workflow perspective, and is technically feasible.
Gotcha. Well, that makes a whole lot of sense. So what makes Diagnosa different? Is it that you're just not consultants, you're clinicians who've built EMR solutions, you lead a team of 20 Epic certified provider builders at UMMC. How does having that clinical background change the solutions you create? And what do you see that a traditional IT team might miss?
One of the things that we've always been very proud of is the work that we do is informed by the clinical care that we provide. And because we are all still practicing clinicians, we won't build and implement something we wouldn't want to use ourselves and have to use ourselves because we all still practice. And so that gives us immediate street cred with our clinical colleagues because they know that we are one of them and we've got to use it too. And so by putting forth a product that or a solution that we feel good about and know will work gives them the reassurance that we have thought about their needs and that we aren't just an analyst in an office or an administrator in an office saying, here's one more thing that we're going to make you do that could potentially be tone deaf. And so I think what sets us apart from other consultants is we live it, so we understand. And also, because we are builders and architects too, we're not just going to give you a PowerPoint deck that says, here's the problems that we've identified and here's how you should solve them. We're actually going to walk through a solution and tell you step by step how we think you should architect a solution, not just leave it up to you to figure out how to solve the problem yourself. I don't think there are a lot of consulting groups with our background and our skill set to be able to offer those kinds of services to healthcare organizations.
Absolutely. The physician, you tell us about the physician builder model you've created at the University of Maryland. How did you recruit bedside clinicians who had an interest in IT? And what's been the impact of having clinical designing their own clinic?
I can't take full credit for setting up the team. One of my mentors, an emergency medicine physician and uh, excellent physician builder architect at the University of Maryland, Dr. Dan Lemkin, is the one who brought me into this world and taught me a lot of what I know. And he established the program initially, but I have been able to help grow its number over the last 5 years since I've taken it over. A lot of folks have an interest in wanting to make things better, and they may not know how to go about it. And so I look for those folks that ask the right questions, have really good suggestions, seem like they want to know what's under the hood of the EMR, or are really interested in process improvement.
Mhm.
I have a lot of conversations and just say, here's what our team can offer you. Does this interest you? Would you like to be able to be part of creating your own solutions? And while not for everybody, what's nice is it doesn't require a tech background. You don't have to have years of coding experience. The training from Epic is free. This is, to be clear, this is EHR dependent. Epic is the EHR solution that offers this kind of training and access, but it is up to each healthcare organization to stand up their own team and give their clinicians the ability to do this kind of work. But it is incredibly empowering to be able to solve your own solutions and not just be frustrated and submit help desk tickets into the void and hope that someone will take pity on your plight and want to help you with an IT solution when there are 100 other competing priorities on the analyst docket all the time. And that's another selling point of the team is that we can help offload work from already overworked analysts by taking some of those provider workflow solutions and building them ourselves.
Wow, that is great. That's commendable. Now, you're taking this beyond UMMC through Diagnosa, right? Who are you working with? Are you targeting health systems, specific departments, or Epic installations specifically?
So we actually have three different approaches to this that we are offering. Number one, in no particular order, healthcare organizations, small or large, that have really sticky workflows. Maybe they don't have the resources or the expertise to be able to understand how to customize their EHR in a way that really solves the problem. I think a lot I don't want to say a lot, but I know there are some organizations who really just want to stick to out of the box as much as possible. Um, and at a certain point, out of the box is not going to cut it for everybody. And one of the benefits of Epic is they empower healthcare organizations to be able to customize the software enough to solve their own unique problems. And I think that's a benefit to them as they say, listen, we know we can't possibly accommodate every unique workflow that's out there. We would love to give you the opportunity to be able to do some of that yourself. So, helping healthcare organizations get the most out of the EHR that they've already paid for is something that we can help with, whether it's one workflow or 10 workflows, depending on what their need is.
Mhm.
And we can do it in a part-time basis so they don't need to have that many analysts and folks on staff year round. This is something that we can help with on a case by case basis. Number two is that we can help healthcare organizations stand up their own physician builder team and not just, hey, here's how to recruit, but here's how to do the contracting. Here's how to sell your organization on the benefits. Here's how to recruit, how to integrate with your existing IT governance structure. And then we can mentor their new builders. We know from experience that it takes about a year until new builders really get the confidence and experience to be able to put out meaningful projects. And so, us being able to offer in services and workshops and direct one-on-one mentoring enables their builders to get up to speed and be productive that much faster. So when we leave, we are leaving them with a self-sustaining team that can continue the work without us. And then the third offer is that we are willing to partner with healthcare tech companies as they are building technology. Everybody is in the healthcare AI space right now, but AI or not, there's a lot of healthcare tech out there, and there are great people doing great work to solve problems that EHRs can't solve right now. But they sometimes are designed and built without a lot of frontline real world stress testing.
Mhm.
And so we can offer some guidance, advisory guidance, or let us stress test your product. Let us make sure that you are designing the best possible product so that you have the highest likelihood of it being purchased and implemented and be successful, because no one wants to spend some money on software that they aren't sure that their clinicians are going to use or not. And so by letting us review it, stress test it, and give guidance on implementation strategies, there's a higher likelihood of success there.
Absolutely. Totally agree with you. You mentioned, on your site, solutions that are clinically relevant, innovated, automated, and customized. Can you give us a concrete example on what tool or workflow you've built that has made clinicians say, this actually makes my life better?
There's a whole lot of them. Actually, there's one on behalf of University of Maryland, unrelated to our company, but on behalf of University of Maryland, that will be presented at HIMSS 2026 in March. If anybody will be attending, is a solution that is entirely was clinician driven, which was how do we make sure that everybody on the care team knows who the primary responsible provider is for any patient at any point in their hospital care at any one time. In 2020, we launched this in 2024. You wouldn't think that that would still be a question, but in an era where, work hours are scrutinized and limited and there's a lot of team-based care, cross coverage, um, there's often that question of who should I be messaging right now when I have a critical need for this patient, whether it's a lab value or a nurse with a change in clinical status, a consultant with a question. We said, let's make sure that that is visible 100% of the time. And we did that within the confines of our EHR. I believe the feedback was this is the greatest thing since the air fryer,
Wow.
which is apparently the new benchmark beyond sliced bread. It is now the air fryer. We've built um, checklists. We've built, that are automated and intuitive and mm, leverage data that's already in a patient's chart so that you don't have to go searching for it. We've built custom tools that help you document a patient's personal story. There's a national initiative that was initially founded through the Veterans Administration called My Life, My Story, where it's about how you bring the personal aspect of healthcare into the hospital, into their patient records, so that the care team really gets to know their patients beyond their disease and to the human that they are. And we presented this at one of Epic's conferences on how to make that more front and center and easily accessible by all care team members.
Wow.
I could go on all day, but those are some of the ones that I think that we're most proud of. And it's not always big. Sometimes it's just minor tweaks in how the clinical decision support looks, or making data more visible and accessible so that you don't have to spend as much time looking for what you need in order to make good decisions for the patient, or making sure when you document that you have access to all the information so that it goes into your note for good billing. There's so many opportunities for intuitive solutions to be implemented into your EHR that don't take hundreds of thousands of dollars and massive, customizations, but they just take someone who knows where the benefit is and knows the right way to implement it.
Makes perfect sense. EMRs aren't going away. If anything, they're becoming more complex with AI, interoperability requirements, and value based care metrics. Where do you see clinical informatics headed? What needs to evolve for these systems to truly support clinicians instead of burning them out?
Oh boy, that's a loaded question. I think that, like everything, clinical informatics needs to evolve as the technology is evolving. And it's so hard. It's like drinking from a fire hose. The AI market has absolutely exploded, and trying to keep up with every startup that comes out and weed out what works and what doesn't is really hard. But I think developing AI literacy and understanding when the opportunities call for a third party solution versus when you should be looking at optimizing the systems that you already have are one of the, I think, best ways that you can be useful as a clinical informaticist or an informatics informed clinician.
Mhm.
I think that technology is going to continue to evolve rapidly because there is just such a need to revolutionize healthcare. There's a lot that is still very archaic. We are still very new in this journey of revolutionizing healthcare, and there are 100 opportunities. But being a discerning customer, knowing how to differentiate between good solutions and solutions that probably aren't going to last, aren't sustainable, aren't worth the investment. Even free pilots are, I think the quote was at least $1 million in resource in terms of investment. And so understanding where that value is and being able to recommend what is going to have the highest value for the clinicians, for the administrators, and then really just a focus on workflow. You have to understand the workflows of the folks that you represent. If you are not a practicing clinician, but you are an informaticist, you need to be that workflow expert. You need to be a very discerning customer when it comes to workflow solutions, and evaluate it from a standpoint of, is this something that I would want to use? Does this make sense? Is this going to make their lives easier? Will it make it better for them to take care of patients? And if not, that's not your solution.
Absolutely. Well, Tiffany, this has been an incredible value. The work you're doing to give clinicians a voice and how their tools are built is so needed. I really appreciate your time and insight today. I'm, sort of looking in your background, seeing your EPIC certifications. I have spent my entire lifetime working with and for clinicians because I'm an Epic analyst myself. So 20 plus years in the industry. My specialty is in and around Epic security. So I work very closely with all the application teams to make sure that their workflows that they're creating are the most optimal as it relates to the clinician. So totally understand that this is so much bigger. How many clicks, is the physician going to have to make when they're actually going through it and doing their documentation in the EMR. And just dealing with just the day-to-day frustrations that clinicians have as they're moving and implementing Epic and or some other EMR solution. It's difficult because they've been doing it one way. It took them a long time to learn that process flow. Now they have to adopt a whole new technology. So totally get it. Understand.
Nobody likes
Nobody likes
nobody
change.
likes when you move their cheese.
Absolutely. Oh, it's a tough, industry, and, the work that you guys are doing at Diagnosa is absolutely imperative and vital to help the clinicians to feel comfortable in those transitions, because I think one of the hardest things as an epic security analyst for me is, user adoption and helping those provider types to feel comfortable in that space and to know that, I've had, physicians say, "You guys are going to a new EMR, I quit." And they leave because they don't wanna go through that stress and that strain of that change that's actually happening, and if there aren't things that are put in place to help them to optimize, personalize and, get them comfortable with the system, they, typically get pretty frustrated. Diagnosing the work you guys are doing is absolutely phenomenal. I commend you for that.
Well, thank you. It's like I said at the beginning, this is all about us wanting to help our fellow clinicians. Anything that we can do to help our clinicians be more face to face and less face to computer is a win in our book. And that's why we all got into medicine. And so, if we can take our tech experience and help our fellow clinicians enjoy their jobs again, since we all burnt out after COVID, and ever increasing requirements to our jobs every day, then I think we will consider ourselves very lucky and very successful.
Absolutely.
Well, I could talk to you about this all day. This is obviously a passion project as much as it is a job and a side job, as it were. I think I just where I hope that our industry is going is to recognize that there are a lot of opportunities to be both excellent clinicians, be high quality safety, and not have our technology be just a necessary burden, but really have it allow us to be really efficient, well informed, and really take advantage of what this technology has to offer. The sky is the limit. Like I said, we've barely touched the surface yet. And I think it's really exciting, but I think we need to be thoughtful about it. And we would love to help organizations not spend a fortune, but still be able to give their clinicians a better experience. And anything that we can do to help, I think we are eager to do that. We are a big fan of work smarter, not harder, and I think we take that approach when we are looking for thoughtful workflow solutions.
Absolutely. Well, again, I thank you, Tiffany. Thank you for joining us. It has been a privilege and an honor.
I did want to mention one of the benefits of Diagnosa is the breadth of experience that we have from a clinical standpoint. I have two phenomenal partners, Dara, who is a med peds physician. Who has a lot of specialty in CDI query coding, documentation, integrity, and improvement, and Casey, who is a pediatric critical care nurse practitioner. She has also done a lot of work on the automation and analytics side. And so I think between the three of us, we have a really broad knowledge of various specialties and practice environments that we can offer to our clients.
Awesome. Well, thank you for that ad. Definitely, we appreciate your time and thank you for allowing us to hear your story and share via the digital dose. Thank
Thank you
you.
so much for having me.
You're welcome.